wait for some more time? Okay, so we can start. Give me a moment. Okay, we are starting then. Yeah. Good evening, everyone, and welcome to bi-weekly CSI Connect program. जैसे कि आप लोग सभी इस सीरीज के बारे में जानते हैं, we invite doctors, we invite other survivors, cancer caregivers, so that they can come and share the journey. बाकी लोगों को इंस्पायर करने के लिए, मोटिवेट करने के लिए, एनकरेज करने के लिए, और इसी में एक स्पेशल हमारा रहता है कि हम डॉक्टर्स को इनवाइट करें जो इस बारे में हमें जानकारी देते हैं कि कैंसर के क्या क्या ट्रीटमेंट्स हैं, क्या हमें इश्यूज हो सकते हैं, क्या क्या ऑप्शंस हमारे साथ सामने अवेलेबल होते हैं, या फिर अगर कोई स्क्रीनिंग की जा सकती है। सो उसी सीरीज में हम लोग डॉक्टर्स को इनवाइट करते हैं। इससे पहले कि आई टॉक अबाउट अवर टुडेज स्पीकर, I'll give some brief introduction about the group. CSI is a cancer support group. It's a cancer survivors group in India, which was started by Savan in 2017. और gradually जो है आज हम लोग almost 3.5K members हैं इसमें, and there are people like Mehul Ahmed, Piyush, and अनुराधा जी एंड बाकी लोग जो लोग हम लोग बैकग्राउंड में हम लोग we are trying to do our best. This group's main motive is to help other patients in whatever way possible, चाहे वो इमोशनल सपोर्ट है या फिर ट्रीटमेंट के बारे में उनकी कोई क्वेरी है, उससे रिलेटेड हम लोग कोशिश करते हैं कि उनकी जो कैंसर के साथ की जो जर्नी है वो बहुत आसान तो नहीं की जा सकती, लेकिन जितनी कम उनको परेशानी हो वो हम लोग कर पाए. Idea is to provide social and psychological and emotional support to cancer patients, and motivate them, and to raise awareness about cancer diagnosis and educate regarding different lines of treatment, and to work towards removing social stigma about cancer in the society. As we know, a lot of time people, they don't want to come in front and they don't want to talk publicly about their disease, क्योंकि इससे रिलेटेड बहुत स्टिग्मा हमारी सोसाइटी में है. तो वो भी एक हमारा एक एरिया है जहाँ पे हम लोग काम करना चाह रहे हैं और कर भी रहे हैं. Then there is a cancer advocacy, research and government support, and to develop economic and matrimonial avenues. We know that एक पेशेंट मतलब सिर्फ ये नहीं होता कि कैंसर का ट्रीटमेंट है, उसके बाद में getting back to normal life, job, marriage, etc. Fundraising is another area. So and I mean there are series of things where we are trying to work, like काफी सारे इसमें people fall into some kind of frauds and we just try to guide them based on the experience other patients had in the past. तो हाँ, इस बारे में अभी ज्यादा ना कहते हुए I'll come to today's topic. So one of the major thing, I mean, which every cancer patient is really worried about more than the disease, their issue is कि what kind of treatment they are going to have, जिसमें से of course डॉक्टर आज हमारे जो स्पीकर हैं वो और भी चीजों के बारे में बात करेंगे, but the focus would be on like chemotherapy. हम लोग इतना घबराते हैं, डरते हैं कि जैसे patient would come and say कि they would deny to take this treatment because side effects से इतना डर है लोगों में, they don't know how to manage. And if I have to remember, मुझे भी लग रहा था कि पता नहीं है तो क्या होने वाला है, कीमोथेरेपी होगी तो मतलब बस because we have that image कि पेशेंट की फ्रेजाइल स्टेट होती है, साइड इफेक्ट्स उनके बहुत बुरे होते हैं. So today we have Dr. Ekta with us, who would be sharing her will be talking about how to deal with the cancer treatment, and we are very honored to have Dr. Ekta today in our session. We will start with the session, and उसके बाद में हम लोग end में अगर कोई भी audience के पास questions होंगे, we will have a Q&A. इससे पहले I hand over to Dr. Ekta. I'll talk about her profile. Dr. Ekta is a senior consultant medical oncologist with the experience of 8 years in the field of oncology. and she is currently practicing at Medisquare Superspeciality Hospital and Research Institute at Ahmedabad. एंड या डॉक्टर एकता जो है मतलब उनको हम सभी CIC ग्रुप की तरफ से बहुत बहुत शुक्रिया. वी आर वेरी थैंकफुल दैट यू हैव एक्सेप्टेड एंड यू आर अवर स्पीकर टुडे. सो काफी टाइम ले लिया मैंने डॉक्टर एकता. नाउ इट्स ओवर टू यू. कैन प्लीज गो अहेड.
First of all, thank you, Mrs. Savita Shekhawat, for inviting me this group to talk this difficult topic, and I would like to congratulate to all the people in this group, because I think that you people are not cancer survivors, you people are cancer warriors. So let us start with how to deal with cancer treatment and its side effects. Though we today we live in a molecular era, but still there are many patients who come to us and they deny further treatment, that I don't want any further treatment for the cancer. You prescribe me only supportive medicine. Our intention of all the treatment, either chemotherapy, target therapy, or immunotherapy, surgery, radiation, anything, intention, it all depends on the intention of the cancer treatment, whether it is cure or control. Or if the intention is cure, then the chances of cure, and if the intention is control, then how long we can control it. So I know everybody will agree at the diagnosis what is the reaction of us, and at the completion of treatment or after fighting with the cancer, how we feel. So basically, the cancer treatment, we can divide it into the three, that is, one is surgery, another is medicines, and the third is radiation oncology. Third is radiation. Radiation, that is, the treatment is given by the radiation oncologist. So in oncomedicines, we can divide it into 5 arms. One is chemotherapy, another is targeted therapy, another is immunotherapy, hormone therapy, and then the supportive care. So what is chemotherapy? So it is like, we can compare it with the Amitabh Bachchan, like it was there, it is, then it will be with us in the cancer treatment. But now we have the therapies with the new flavors. Like now we have the immunotherapies and target therapies, which are the newer therapies. And these two therapies, they don't have the side effects like chemotherapy. So we'll discuss about the side effects of immunotherapy, target therapy, but first we'll talk of the side effects of the chemotherapy. So though there are so many side effects with the chemotherapy, like fatigue, nausea, vomiting, loss of taste, dull mood, diarrhea, constipation, some people may get infections. There are some long-term side effects like neuropathy, myopathy, or cardiotoxicity, organ failure, etc. And there are some long-term toxicities like sterility, heart toxicity, or secondary cancers. So when the patient is very young, unmarried, or married, but still they don't have kids, so before giving some regimens of chemotherapy, we advise them to do fertility preservation, to considering these long-term toxicities of the chemotherapy. But now we have so many supportive medicines to minimize the side effects of the chemotherapy. Like we have potent antiemetics, so that with the help of these potent antiemetics, our patients, even they don't have the vomiting or frequent vomiting or even nausea, which they face, which our patients they face before 5 to 7 years, because now we have a range of antiemetics, range of molecules. We have growth factors to minimize the side effects like low hemoglobin, low WBC count, to prevent infections. We give after the cycles of chemotherapy this type of growth factors so that they don't prone to extra infections because of the low immunity. We sometimes need to prescribe appetizers. We do have now chemotherapy options with no alopecia. We now do have the options of pot insertions. The pot is some small button like tool which we insert over the chest under the skin, so that the peripheral veins, they do not expose to chemotherapy and its side effects. So if we talk of drugs for vomiting, then we have the range of drugs in which some are very newer generations and to be taken once only, or single tablet only, or single injections only, and patient, they don't need to take the tablets of vomiting throughout the treatment period, throughout the chemotherapy period. So we have, as we discussed, we have growth factors to prevent a low WBC count. We have growth factors to prevent low platelet counts. We have growth factors to prevent low hemoglobin. And these are two devoid of toxicity. So patient can easily, we can easily manage the intensities of the chemotherapy. So we have now the molecules with the subcutaneous mode of administration. If you are a breast cancer, then you must have come to know the trastuzumab, or you must have taken trastuzumab if you are a positive breast cancer. Now we have the trastuzumab with the subcutaneous mode of administration. So patient does not require to get admitted or does not require hospitalization. And with the subcutaneous injections, we can treat our patients of breast cancers. Now we have the so many newer preparations which combines the different molecules. So patient does not need repeated injections or longer durations of chemotherapy. We have now so many newer molecules which we were used to give in the injection form, and now we have those injections in a tablet form now. So for chemotherapy, the fear is like majority of the people, we can see the half knowledge is worse than the no knowledge or zero knowledge. So, and the main fear among women is alopecia. So a doctor is saying to her patient that at least yours will grow back, though mine will never come back. So many times we cannot avoid or prevent alopecia, but we should know that it's a temporary and reversible. It is not a permanent baldness with the chemotherapy. So anybody can interrupt me at any time if they don't understand or if they have any questions related to any of my slides. So just to share this message that the patients on chemotherapy, this combination is not so difficult or deadlier, which were previously before 10-15 years. Now a woman with a breast cancer on chemotherapy can do her routine life, can go to teach students, can go to buy vegetables, or can take care of her family too. While a man with flu, cough, cold and fever, he has to take rest. So now we'll discuss something about this targeted therapies and immunotherapies. Now, what is this targeted therapy? What chemotherapy does, it damages, though it kills the cancer cell, but it damages the normal cells too, the rapidly dividing cells of our body, like scalp. So alopecia can occur like a mucosa of our oral cavity, so that mouth ulcers can occur, diarrhea can occur with the chemotherapy. But this targeted therapy, after going inside our body, it targets only cancer cells. So it is devoid of the side effects of chemotherapy. So the mechanism is at several levels. It is like smart bomb versus a cluster bomb. See, now we have the range of targeted therapies, a range of immunotherapies. with indications, FDA approved indications or DCGI approved indications in so many cancers, and it is widely available even in our country. Almost each and every target therapy or immunotherapy, almost they are available to treat our patients. So they may come in injectable form like monoclonal antibodies, or they may come in the tablet form. Small synthetic molecules, or patient has to take a single tablet, and we can treat similarly like hypertension and diabetes to our patients. So we'll not go detail in this medical slides. So target therapies, they act on a specific molecular targets that are associated with cancer, while standard chemotherapies act on all the rapidly dividing normal and cancerous cells. So this is the main difference. And now what is immunotherapy? Immunotherapy uses our own immune system to kill these cancer cells. So with chemotherapy, we see hair loss, intestinal damage, nausea and all. And with target therapy, they have a specific side effects, but they are not so severe as with the chemotherapy. And similarly, with the immunotherapy, we see the side effects related to autoimmune system. So here I want to share two cases to show the effect of this targeted therapy. 36-year-old male. This is my patient, tobacco chewer, a buccal mucosa cancer, locally advanced, with skin involvement, stage 3. So he was started with the chemotherapy, but unfortunately that patient has not responded to my chemotherapy, and the patient was referred to palliative treatment or further treatment to us. This was his first lesion when he was referred to us. And this was his second lesions where chemotherapy has not worked and the disease has progressed. And patient was started with the tablet erlotinib. That is the target therapy, and his mass reduced by almost 50%. So here is another 44-year-old male, tobacco chewer, treated with surgery, buccal mucosa cancer, treated with surgery 3 times. And again, patient developed with the similar recurrent lesions over the cheek. And after starting this erlotinib, a targeted therapy, within 2 months, that lesion disappeared. And so ultimately, what I want to convey is patient was treated with a tablet that is devoid of the side effects like chemotherapy, and the response is also a very good, much better than chemotherapy. And now we'll talk of immunotherapy. See, we can't offer target therapy or immunotherapy to each and every our patients. So there has to be some molecular study before prescribing this target therapy or immunotherapy. So for immunotherapy, we usually advise MSI, TMP or PDL1. These are the medical terminology. So these are the molecular tests we advise before starting immunotherapy, or before concluding that this patient will get benefit from the immunotherapy or not. So now we have this immune checkpoint inhibitors or immunotherapy in multiple cancers. You can see the list of the cancer. We have so many wide range of indications, and we can offer so many patients these therapies. And now we'll discuss about the some side effects of target therapy and immunotherapy. For target therapy, for this tablet erlotinib or similar target therapies, we usually see the skin toxicities like rashes, acneiform rashes, dry skin, or some hair toxicity, but not hair fall. We see diarrhea, or we see the long-term toxicities on the heart, bleeding, etc. But the bleeding or some serious diabetes, they are very rare as compared to chemotherapy. If we talk of immunotherapy, we usually see the side effects related to endocrine glands like diabetes, thyroid, inflammation of any endocrine organs, or lung toxicities very rarely. So things to do while on the treatment, these are the common points we all have to take care. See, if you're a cancer patient, if you are on a treatment, or if you are a cancer survivor, then physical exercise or to maintain healthy body weight is very much required, because in various trials it has been proven that healthy body weight prevents the chances of recurrence of the disease. So exercise should be a part of your routine activities. It is advised to discontinue smoking alcohol while on treatment or after the treatment to prevent the chances of recurrence. Yeah, of course, balanced diet is required. If you are on the treatment of chemotherapies, then probably your immunity is low. Then at that time you have, if you are planning to go to crowded places, wear mask to prevent infection. Don't mix alternative allopathy medicines. Many of the times patients come to us that we want to continue these medicines too, but there are some drug interactions between two different drugs. So if we combine the two different drugs and where we miss this drug interactions, then there may be no response or there may be a high toxicities. So to follow your doctor's instruction is very important. See, when the cancer is detected in the family, there are so many relatives, so many, even the people who don't know or who are not so very close, they come to us and they start giving advices, you do this and you do that. But I think to follow your doctor is very critical and very much needed thing. Regular checkup and surveillance is needed even after completion of the treatment. And one more thing I would like to highlight is avoid overuse of PET CT scan for surveillance purpose. We all know the one CT scan is equal to 1000 X-ray. The radiation with CT scan is very high, and it is even higher with the PET CT scan. So to avoid overuse of PET CT scan, specifically in surveillance, while after the completion of treatment, when you're looking for recurrence. And stay away from the myths like don't eat sugar if you are a cancer patient. So it is a myth and you should not follow. Thank you. So I would like to invite questions if any.
Yeah.
Please.
Yeah. Thank you, Dr. Ekta, for your presentation. Even I also have questions, but before that, I would like anyone else in the audience, if any questions you have, please feel free to ask, raise your hands and unmute yourself. Yeah. Anyone?
May I ask?
Yes, Anuradha ji, please.
हाँ डॉक्टर एकता, मैं जानना चाहती हूँ कि ये स्टेज पे डिपेंड करता है कि आप टारगेटेड थेरेपी देंगे, इम्यूनोथेरेपी, या पेशेंट की जो रिपोर्ट्स हैं उसके ऊपर, मतलब स्टेज का रिलेटेड है या ऐसा कुछ नहीं है कि स्टेज से रिलेटेड है?
नहीं, see, we cannot offer this newer therapies to everyone. It is definitely depend on the type of cancer, which cancer you have, at which stage you are diagnosed. In the majority of the cases, we have this approval in a stage 4 patients to prevent progression or to control the disease. But nowadays, in many cancers, we have this therapies, newer therapies in the adjuvant or neoadjuvant setting. It means before surgery, we can use these therapies to regress the primary tumor, and so that the surgery will be easier, or post the surgery to prevent recurrence. Now we have the latest so many newer data to treat in early stages too. So, but it all the times it depends on the type of cancers you have, whether that drug is approved in that cancer and at this stage or not, that your doctor can guide.
ओके, वन मोर क्वेश्चन कि मैम, अगर हम रेगुलर जो हम कीमोथेरेपी देते हैं और जो ड्रग्स रहते हैं उसके अलावा अगर जैसे टारगेटेड थेरेपी दे देते हैं और उसके बाद भी पेशेंट को रिकरेंस या ऐसा कुछ होता है, तो डू वी हैव एनी ऑप्शन कि उसको आगे कैसे ट्रीट करना है?
See, there is no treatment so far which is 100% effective. See, we even with the targeted therapies, in the immunotherapies, we have some data with 70, 60, 70%, 70 to 80%. Say, for example, if we talk of a lung cancer, in a stage 4, the response rate of chemotherapy ranges from 50 to 60%. But if we treat with the target therapies, then the response rate ranges between 70 to 80%. But still, we don't have the 100% response rate with any of this drug, because the mechanism or the molecular profile of cancer is diverse. The cancer cell, it finds the way to escape this our weapons, how to escape from your treatment. They are very diverse, and yet so many newer drugs are coming up. So probably near future we will have that something new therapy where we can say, okay, now you will be surely or 100% can be cured in probably majority of the cases, but not at present.
Thank you.
Thank you, Anuradha ji. पुनीत कुमार जी शायद कुछ पूछना चाह रहे हैं. Yes, पुनीत जी.
Good afternoon, ma'am. My wife is diagnosed with Ewing sarcoma, and her treatment, 3 cycles of chemos are done. Now, my question is whether we can give some Ayurvedic medicines to increase her stamina, like someone says Swan Bhasma, Abrak Bhasma, etc.
So my strong advice to all of you that you should not mix allopathy with the alternative medicines. Now, many of the time you choose one pathway from the beginning, whether you want to continue allopathy or whether you want to continue alternative medicines. Because in many of the times what happens with these alternative medicines, we don't know sometimes the content, and we cannot sometimes know the interaction between those two drugs. And even if sometimes we get the response, then we cannot conclusively say that the response is because of this drug or response is because of that drug. And sometimes we see the toxicities, and we cannot say which drug has caused toxicity. So better not to combine two modes of treatment.
Okay, one more thing. This was not for treatment. This was just for immunity, which is down because of chemotherapy.
So
this is not alternative
keep your immunity
treatment.
better. As I discussed, we now have so many range of growth factors, right? Apart from that, if you are suppose your Ayurvedic doctor is confident that their drugs will not discuss with our, will not interact with our drugs, then probably you can continue that supportive medicines.
Okay, and one more thing, like you said, we should not believe on myths like no sugar. So here, someone say, I have heard from many people.
So many people says to our cancer patients that don't eat too much sugar or you cut down sugar completely. But see, it becomes disaster when a patient is suffering from a cancer somewhere between that food pipe to stomach or buccal mucosa or C, because patient has already lost so many kg weight. And with the treatment also his or her appetite is low. And in this situation, if you cut down, if you are not a diabetes and you cut down his or her sugar, then patient keep on losing weight and ultimately she or he becomes the bedridden. So in the non-diabetic patients, in patients where they are losing weight because of cancer or chemotherapy, we advise to take high protein, high calorie diet to maintain their weight. Unless until you are suffering from diabetes or you are obese or your weight loss is your goal, then you should not cut down your sugar, because there should be no weight loss while on treatment, because any energy, it depends on the what you eat. There are not so wonderful drugs which can maintain your energy while on chemotherapy. So adequate food, adequate calorie, adequate protein is extremely important while on treatment.
Someone said that we should not eat wheat as well. Wheat.
Wheat?
Yes.
So it is not proven in any scientific trial or any randomized trial. So I think we should avoid of this meat.
Okay, thank you, ma'am.
None of the textbooks they mention to avoid sugar or wheat.
Okay, ma'am. Thank you very much.
Thank you, Puniji, and thank you, Dr. Ekta. So there is one more person. I don't know the name. Redmi 8.
Yeah, ma'am, my name is Shelly. एक्चुअली हमारे केस में क्या है कि आफ्टर कीमोथेरेपी सेशंस हमने दूसरा ट्रीटमेंट लिया है विच इज अभी स्टार्ट किया लुटेशियम 177 PSMA. सो ये जो है इज दैट अ टारगेटेड ट्रीटमेंट? हेलो. कीमोथेरेपी सेशंस के बाद अभी जो हमें नेक्स्ट ट्रीटमेंट हमने स्टार्ट किया है वो है लुटेशियम 177 PSMA ट्रीटमेंट.
So your patient is a case of
प्रोस्टेट कैंसर. प्रोस्टेट कैंसर के बाद इट वाज मेटास्टेटाइज्ड इनटू बोन कैंसर, तो इसीलिए उनको फिर
So
वो
I think the therapy you are received is to be preferred in third, fourth line. So probably
हाँ.
all the lines of the treatment, like so many hormonal therapies, docetaxel, cabazitaxel, all the lines of previous therapies are used, and even if then the patient is symptomatic or metastatic disease or bony mets are there, then
हाँ.
you can choose this therapy. Then the
We have
nuclear
already
medicine.
started. या हम लोगों ने ऑलरेडी उसका एक सेशन ले लिया है, तो उसके जो साइड इफेक्ट्स हैं उसको कैसे मैनेज करना है, उसमें
So
किस तरह के साइड इफेक्ट.
probably that is the subject of nuclear medicine specialist, so they can guide you
Okay.
better.
ओके. ओके. ऑलराइट. थैंक यू.
Okay, thank you. Anyone else have anything to ask or say? Okay. I mean, मेरा खुद का एक क्वेश्चन. अच्छा पीयूष, या पीयूष आप पूछ लीजिए.
हेलो मैम, ये अपना जो ट्रास्टाजुमेब सब क्यों आप बता रहे हैं अभी, तो ये अवेलेबल होगा है क्या मार्केट में?
हाँ, definitely.
एंड व्हाट इज द कॉस्ट ऑफ दैट?
That I need to ask what Roche is making. And now we have the combination of trastuzumab plus pertuzumab. So initially we had to use the different trastuzumab administration, different mode of pertuzumab administration. And now we have the combination of both, and probably at a cheaper rate than the previous IV preparations.
Okay, so that sub Q even patients can take by himself at home only?
No, not by himself. Some medical personnel should be there, but definitely I think you may not require hospitalization, but probably on OPD basis you can take the subcutaneous mode of injection.
Okay, and this one more thing is that I have seen many patients who are complaining about the headache after getting Neupogen or filgrastim. So on that is not being explained by most of the medical oncologists, but that is commonly observed. Though is it written somewhere in the product monograph of the Neupogen?
So PAG GCSF, that is the PAG filgrastim or say plain filgrastim, the joint pain, body ache, headache for up to 48 to 72 hours. It is the extremely common side effects, and majority of the patients they face. But probably a simple dolo or paracetamol can take care of that initial 2 days post drug. And probably I think it has written in the monogram too, because it is the commonest side effect of this filgrastim.
And most GI cancer patients have the issue with the weight maintain or the weight gain, and every patient must be trying for the weight gain or to maintain the weight with different available options like protein powders, high protein diets, and everything. But even I've seen many patients, or most of the patients are not able to gain or maintain the weight.
So what happens if you become ill? Then what they do, they start eating fruits and fruit juices and light diet or khichdi and etc. So to gain your weight, fruits will not help you. Rather, fruits can help you losing your weight. So you not only require high protein, but high calorie diet is also required. Like what we say in Gujarati, like you eat siro, sukdi, ladwa, thepla, or kind of. So high calorie diet is also like ghee, milk, dry fruit, like pulses, wheat. So all these things required to gain your weight. And there are possibilities because of chemotherapy. You may have altered taste in your mouth. You may have anhedonia, like loss of interest in the food. So all this play their role. But for diet, definitely we should encourage in high calorie. If they are non-diabetic, then high calorie along with high protein may be helpful.
Okay, thank you, ma'am.
Thank you, Piyush Rai. Dr. Ekta, I have this question for you. So there are two questions. So number one is it possible in some cases that chemotherapy can be skipped and patient can directly go for targeted therapy?
Yeah, definitely. When if indication is there, we usually avoid chemotherapy if there are molecular study, they have the positive mutations and we have target therapy against that mutation, then we avoid chemotherapy and we start with the targeted therapy first. We reserve chemotherapy in the second, third line because they are devoid of toxicity and because they are more efficacious. Rather, considering toxicity only, as efficacy is high as compared to chemotherapy, we use upfront in many of the indications.
Okay, that's a good news. I mean, if that's a possibility. Another question is for this WPC shots. I mean, for after every chemotherapy, these are prescribed by medical oncologist. But patients normally complain lot of side effects, and they are very reluctant to take these shots. And for younger patients, like I mean, I remember my case where my doctor has decided finally that it was not needed, looking at my WBC counts. So is it okay to talk to the doctor?
See,
Yeah.
PEG GCSF injections, there are classic indications. They are to be used with some regimens, they are to be used with some molecules and at some age, in some age groups only. So there are so many regimens why we don't routinely use, but we have to use in the second or subsequent cycles if they have some more toxicity with the first cycles. Suppose if in place of 21 days cycle, if we are planning every 14 days cycle, then we have to use these growth factors. In spite of the known side effects, we have to use because the neutropenia, low WBC count and the infection because of this low WBC count, they are deadlier as compared to the side effects of PEG GCSF. So whenever the indication is there, we have to use and we should not worry of the side effects of these injections because the infections can take your life. So the side effects are very manageable of this PEG GCSF or this you just said the shots of immunity shots.
Okay. Yeah, because I'm in touch with one of the patient and she's really reluctant and she has fainted and she's suffering a lot and she want to skip this particular medication for her WBC.
So in that case, we do have other preparations too. We can try a different if it is mandatory. If it is not mandatory, then we can omit also.
Okay.
But then we have to be very much careful regarding acquiring infections. So probably the care should be like face mask, sterilium, or hygiene should be more vigorous.
Okay. Okay. Yeah. Yeah. Thank you. So that's I mean I had these many questions. Anybody else, if they have anything to ask, please feel free to unmute yourself and ask. But हाँ बहुत ही आपका हाँ Mehul please go ahead.
Hi, Dr. Ekta. Thank you for this wonderful session. Got to learn a lot. I'm a stage 4 throat cancer survivor and I have been treated with chemo and radiation. I don't have any specific question, but I come across a lot of questions like they were generally asked, like the weight loss and how to manage weight. And so I was treated in the US at the James Cancer in Ohio. And the first thing the doctors did here was they put in an PEG tube in my stomach, the feeding tube. And that was really fantastic. It really helped me maintain my weight. My treatment lasted for over a year. And it was there even 6 months, almost over 6 months after my treatment was over in my stomach. They were not sure if the cancer would come back. They just wanted to, before they removed it. But I was it had become a part of my body and integrated like daily life. It was not a trouble. I used to go to work with that tube in my stomach. But in India, I see that that's not spoken of a lot when it is actually so convenient. And I just had to take that liquid ensure and put it in that tube, and I was fine. And life was really good with that PEG tube. Why is it so that PEG tubes are not so encouraged, or is it?
So from that tube, I think liquid is going inside, right?
Yeah, yes.
So when you are unable to take liquid food, then you need to have this PEG tube. So
Okay.
you're getting me. So if you are not able to eat solid food, then okay. If you are still eating liquid, then you don't need to do any rice tube from the nose or from the stomach. Okay.
Okay.
If you are taking liquids orally, then these tubes are not required. But if you are having difficulty because of the cancer or because of the cancer treatment, many of the times radiation may hamper your even liquids going inside easily. Then you have to have some alternative like nasolacrimal, like rice tube, or somewhat like PEG tube. So in that case, we definitely advise, and but very minority of the patients they require this PEG insertion because of the dysphagia.
Okay, okay.
And
Yeah,
it
that
requires
makes
a
sense,
surgical,
right?
small surgical procedure, and sometimes simple rice tube can it's a OPD procedure, so it can replace the PEG. So the complication with the rice tube is to be inserted from the nose, and you have a minimal complication with that as compared to PEG. Right.
Got it. Yeah, that makes sense. If you cannot drink, because some patients, they don't like to eat and drink. So I suggest to ask that some doctors with a PEG tube that if you don't like to eat and drink,
So you
during
don't
chemo,
like to eat, don't like to drink, or you are not able to drink. That is a different thing.
different
So
thing, yeah.
So because you don't like to drink, for that reason we can't advise them to insert this PEG.
Okay. Okay, got it. And yeah, thank you. That really makes some good explanation. But one more thing for Mr. Puneet, who asked the first question about the myths, sugar, wheat, and all. So Puneet, I'm a stage 4 the throat cancer survivor. Look at me. I never stopped sugar. I never stopped eating ice cream or anything. And these all are myths. So please don't get into it. Don't listen to that someone. Stay away from someone and not away from sugar and all those that are going to help you. So
Okay, sir.
yeah, I keep telling people that if you want to become a survivor like me, I'm past 8 years, but I was never advised to stop anything. Yeah, keep it in limits. Keep your doctor informed. If you have problem with some food, you should stay away from it. But किसी ने ये बोला, किसी ने वो बोला, तो मैं नहीं करूँगा. All is wrong. I have eaten everything and I am healthy and fine now. So yeah, please.
So I think to advise or anything to follow, there should be some recommendations, some guidelines, some data, clinical trials, and there should be some evidence to say no or to say yes. And for that, I think medical oncologists or any cancer specialist, they study almost 11-12 years after the 12th. So if anybody comes and give you advice, then we should not follow. Rather, we should follow medical advice by medical personnel who's sufficiently expert in that subject.
Okay, ma'am. Thank you very much.
Yes, thank you for your questions, Mehul. And एक चीज जो डॉक्टर एकता ने बोली थी, मैं भी उनमें से हूँ, और बहुत सारे पेशेंट ऐसा करते हैं अपने मेडिकल ऑन्कोलॉजिस्ट को जाके कि आई वांट टू हैव दिस पर्टिकुलर आयुर्वेदा एंड ये वो, कैन आई हैव दैट? एंड आई रिमेम्बर डॉक्टर सेइंग कि आई बेग यू, तो मेरा ट्रीटमेंट ले लो पहले, बाद में तुम्हें जो करना है करो, डोंट इंटरफेयर विद माय ट्रीटमेंट. सो नाउ इट मेक्स सेंस कि they are more literally worried about what about their treatment, and हम लोग उसमें कुछ बीच में घुसा के अपना दिमाग चला के कुछ कर लेते हैं. And that is one of the reason कि we tell people, and you were very apt when you just said to the point कि आप mix मत करिए, we don't know what's happening, and people fall for this क्योंकि शुरू में तो डर जाते हैं, लगता है कि कुछ करके जान बच जाए, but it may harm. That makes sense. So yeah, it had been really very interesting and informative session, Dr. Ekta, and thank you so much for taking out your time. And thank you, Archana ji, and thank you, Piyush ji, for connecting us with Dr. Ekta. I mean, that's how we got her connected with her, and she could make it. Piyush, you want to say something? I see your hand raised.
I have one question to Dr. Ekta, that yesterday one patient came to me and he sent me a report of patient. The patient is diagnosed with the cervical cancer, and the MRI report of dated 13th of February this month only, that was showing liver metastasis, and doctor had a doubt. That's why he asked the patients for the PET CT scans. Yesterday they went for the PET CT scan, and the PET CT scan shows disease is locally advanced only. So which report they should rely on, and how they can proceed? Go ahead.
So definitely PET is more sensitive because it is not only showing you the tumor, but it is showing you the activity in the tumor, whether it is active or not. So PET is always more sensitive, but it also depends on where you get done your CT scan, who is reporting, and what is the accuracy of the CT scan machine, and what is the clinical scenario, clinical situation. Na? There should be clinopathoradiological correlation. When a patient is complaining of something, pain in the right or upper abdomen, and you see the images with the liver nodule, then you have to consider it as a MATS, or you may consider it as a MATS. If the patient is asymptomatic and in CT scan they are the doubtful lesions, then PET CT can help you better. And I have seen so many patients, so in so many cases, even PET CT, they can't say you correctly. So in those rare cases, we have to do biopsy to confirm this finding, whether they are cancerous or not. So it is always the clinoradiological correlation or clinopathological correlation based on which we take decisions.
Okay, because what I have seen, that every time when patient is having two reports, the report which is better one, the patient would like to accept that only, and that's why I mean psychologically patient what they feel, that this report is better as compared to this one. So I am not the advanced. My disease is not so much advanced. I'm locally advanced. So this is what actually what you explain.
See, and take decisions psychologically. We usually see patients, we usually correlate their complaints with the reports. We talk to radiologists in this kind of tricky situations. If someone has reported positively, if someone has reported negatively, we talk to them and we take their opinion, we discuss the case with them, and if there is a confusion even after PAT, then we biopsy that lesions to confirm, because if the patient is having disease in the cervix only, and if we are planning to treat her with a curative intent, then it is very much important to rule out the liver metastasis.
Okay.
To rule out the disease in the liver, right? Because the whole treatment will be changed just because liver mets are there or liver mets are not there. So confirmation with the biopsy can help in this kind of difficult cases.
Okay.
Thank you, Piyush. Yeah, thank you. And I would like to invite Anuradha for the closing address.
Thank you, Dr. Ekta. It was very informative session. So many queries were solved. We were able to understand all the types of therapies and when to be given like. So thank you once again from on the basis of CSI, and would love to hear you more sometimes. Or thank you once again. Yeah.
Thank you.
Thank you. हम लोग शायद future में will again reach out to you if we need more such sessions. And
definitely.
And before I close, there's a small token of appreciation for you. I'm reclaiming my host, Mehul bhai. Okay. Otherwise, I won't be able to share. Okay, let me try. Yeah, so let me know when you all can see my screen. This is for you, Dr. Ekta, and I would be emailing it to you as well. and you feel free to share in your social media or wherever you want.
Sure. Thank you.
Sure. Okay. Thank you so much once again. And yeah, मतलब बहुत ही informative था और काफी लोगों के जो सवाल थे वो भी उनको I think they got their answers. And I mean really salute all doctors. हमारे लिए तो doctors angel जैसे हैं जिन्होंने हमारी जान बचाई है, तो they are always on high regard. मतलब कुछ और चीज और comparison ही नहीं है. I think I feel short of words whenever I have to talk about my doctors. For me, next to the God are my doctors. So salute to you. आप लोग इस noble cause में, I mean it's I think thanks word कहना भी बहुत छोटा पड़ता है हमारे लिए. Thank you so much.
Thank you.
Okay. So yeah, we'll close today's session then. Thanks everyone for joining, and we'll putting this video on YouTube for for other audiences as well. Thank you so much. Bye bye.
Thank you. Bye bye.